Next is my topic is DCR but simple and complications. Now we come to simplify this procedure, DCR. Although endonasal endoscopy DCR is getting clinical acceptance and popularity, the external DCR is regarded as the gold standard in terms of surgical success with high patient satisfaction. And personal communication with many ophthalmologists reveal that the failure of the procedure and tedious flap making in DCR are the main cause of reluctance from this surgery. That is why we change the surgery to make this less time consuming, easy to perform, result at par and short learning curve. And changes we made is medial part of the lacrimal sac was removed, saving 2 mm to 3 mm of sac around common canaliculi. Aruga's bone refined is used here to make ostium, and mitomycin C is used on 5th day of syringing in the newly formed passage. And after the initial success, we planned a study, and currently from March 2010 to March 2020, total number of patients we have taken 3768. Methylene blue is used to irrigate lacrimal sac to delineate it during dissection, and curvilinear skin incision was made 1 to 5 mm to 2.5 mm away from medial canthi, like this. Medial 2 to 2 mm to 3 mm of the sac around common canaliculi is shaved so that the lateral part of the sac remains as a disc with punctum in its middle, similar to a funnel. And here A is showing remaining sac after the small flap and tip of the Bowman's capsule coming out of the common canaliculi opening. 10 mm Aruga's bone refined was used to make ostium in lacrimal bone and passage in nasal mucosa. And this one is Aruga's bone refined 10 mm. I used 10 mm. Anterior part of the lacrimal sac. Remaining sac was sutured with the subcutaneous tissue of the medial side, adjacent to newly formed ostium by non-absorbable 6/0 silk thread. Medial palpebral ligament and rest of the incision were sutured. On 5th post-operative day, sac syringing with 1 ml of 0.4 mg per ml mitomycin C was done, and all the cases were followed up for 1 year. No unexpected complication was found during surgery now. And the patient were followed up for 1 year, and functional success was defined as absence of tearing, assessing the Monk score, and epiphora of grade 0 to 1 was considered as a success, and anatomical success was defined as a patient with no significant reflux on a syringing test. And ostium size was measured using nasal endoscope, and in one case this is nasal endoscopy after 1 year, and this is internal nasal opening here. And the endoscopic view after 5 days, and these are the endoscopic view after 15 days, after 1 month, after 3 months, after 6 months, and this one is after 1 year. And the ostium size shrinkage was actually it is not related to this study, and the results were analyzed after end of a study, and 3715, that is 98.66% patients were successful at the end of mean follow-up period, and 21% complained of epiphora of grade 2 or more, and sticky eye despite successful syringing and patent newly formed nasal ostium, and 27 patients failed in syringing during the follow-up periods due to closure at osteotomy site. And thus in our study, anatomical success is 3736, that is 99.15%, and functional success is 98.66%. And speaking some point, in our studies, frequent cause of DCR failure was closure at rhinostomy site and inappropriate size and location of the bony ostium. And we use here 0.4 mg 5 ml because it was found safest and most effective. And why on 5th post-operative? Because in the present study, syringing of 0.4 mg per ml mitomycin in the newly formed lacrimal passage on 5th post-operative day, because it decreased the incidence of post-operative adhesions more significantly because it is not diluted by bleeding from nasal mucosa and better concise to early proliferative phase of healing, which starts from 3rd to 5th day of tissue injury. And we conclude and recommend this method because this method is easy to perform with reliable and comparative result, as you have all seen. Needs no costly instruments, can be used for mass surgery in camps, can be used for repeat and very large diacrititis. And complication, I have to take it. And as usual, hemorrhage, primary or secondary hemorrhage. The most important complication in DCR surgery is sump syndrome. May occur if the rhinostomy is rhinostomy size is small and high up in the lacrimal sac, and this causes tear and mucus to accumulate in the sac and discharge into the eyes. That should be taken care of. Late complication may be rhinostomy, fibrosis, waved facial scar, medial canthal distortion, epiphora, and failed DCR. Thus, we can conclude the most frequent and important complication of DCR was failure and recurrence of epiphora or pleural discharge, and the less frequent complication included a scar formation, wound infection, and granuloma formation. And there was no complication during operation here. And we have had this type of cases by these methods.